Hello and welcome to All the Good Things, the podcast series brought to you by Hugo, your trusted digital health engagement partner in collaboration with the Social Gym. I'm your host Priyanka. I'm the co-founder at Hugo and also a health practitioner from the vibrant city of Dubai. Today we're talking about a really well-known issue. It's called obesity. How frequently do we see people just drawing conclusion out of someone's lifestyle habits? We often put the blame on the individual, that if the individual is overweight, that must be his poor lifestyle choices. But it's not all how it seems. There is more than than what meets the eye. So today, to discuss this important area of topic, how to redefine obesity, it's more than just a personal choice and more of a complex biological condition. We have here with us a very special guest, Dr. Hecham Harb, who is a specialist endocrinologist working with the Emirates Hospital Group. He's also the medical director and co-founder of EndoCare, a clinic which is based in the Dubai Healthcare City. Will share with us his special insights, expert tips, and also important information how to shift the narrative about obesity. So Dr. Hecham Harb, welcome to All the Good Things.
Thanks for inviting me, and it's a pleasure, of course, to raise the awareness about this well-known problem, but probably misunderstood problem.
Yeah, absolutely. Yeah. So if we have to talk about the shift of narrative, what do you think is really the problem? Is it really the personal lifestyle choices that one makes, or is it really the complex biological interplay that really makes the whole
Yeah, see, to start with, I think there was misbelief even among the healthcare providers. The science earlier did not tell us the full story. That's the point. Then the misbelief was focusing only that energy balance, it's about calories in and calories out. Like how you're managing your money, correct? You're earning money. If you have some extra money, you put them in your saving account and using them at some stage if needed. That's applicable in mathematics and physics, but not in biology. Then calories in and calories out, it's not the full story of accumulating fat. Why I'm saying that? Because fat is a strategic energy storage where our body use it if needed at some stage. And historically, if you go back as a human being, we used to fight for food. It's not easy. Then the evolution of brain, led to that always fear of lack of energy. Then in our brain, there is a center, it's called homeostatic center, and that homeostatic center is responsible for one thing only, which is protecting us from energy deficit. Then always there is a concern, then if one day if I don't have enough energy, where I can get this from? Then because of that center in the brain, and there is a survival concerns, calories in and calories out, it's not there. Now, how we increase our energy in the body? Of course, by eating, correct? Then that misbelief led to another misbelief that your eating habits, it's your own choice. You decide when you eat and we decide you stop eating. But if you go to real story that I listen to many people every day, being excessively hungry, it's not your choice. Being less active at some stage is not your choice. There is a very interesting study in UK where they randomized schools depends on their numbers of hours of physical activity. The PE lessons in the school. And there's some schools, they have once a week PE, and other schools there's a 3 times a week PE. Then they put some wearable, watches for those kids to find out what's the physical activity that you do every day?
Right.
Now, at the end of that study, after 6 months, even if you are in that school where you have one PE lesson in a week, if that kid is genetically susceptible to be active, he will be active even at home. He will continue being active even after school. And if you are not susceptible to be active really, then even if you are in the school, you start putting excuse to not do physical activity. Then even being active, there is something genetic. There is something in our brain telling us, no, you should be lazy. Then this misconception or misbelief that simply calories in and calories out led to that blame of people living with obesity, that because you are overeating, you are storing fat.
Correct.
And because you're not physically active, you're not consuming the stored fat to make that balance. But once again, science proved opposite.
So are you trying to say that it's the genetic framework that decides how we make our choices?
100%. Now, in our genes, there is, codes, and those codes telling everything, our eyes color, our hair color, One of that is what's the capacity of the fat storage. Okay?
Okay.
And that's why we believe probably the genetic causes is responsible about 70 to 80% of obesity. Then if you are born to carry 120 kilograms, if you are exposed to the environment which facilitates reaching that level, then you will be there at some stage. That's why you can't compare yourself with others. Then all these codes are embedded in our DNA. But once again, what's the rule of the lifestyle or modern life that we live? I can give you an example of nuts allergy. Always there is a problem with the nuts allergy.
Yeah.
Every 2-3 weeks, we got a letter from the school teachers, don't please put nuts in the lunchbox, correct?
Yeah.
Because of the nut allergy.
Yeah.
Then nut allergy, yes, it's a new problem. It's not a very old problem. And I can't blame nuts only. Because I eat nuts, I don't feel any problems. You eat nuts, you don't feel any problem. Then regardless of the external causes of nuts allergy, there's a problem in the immune system.
Absolutely.
The immune system reacts differently. That's why you have nuts allergy.
Yeah.
Once again here, regardless of the modern lifestyle we know that, very well, eating, drinking, physical activity, sleep, stress, all these things may lead to increased body weight. But if you are not susceptible to gain weight, wouldn't be very evident to see that. Then if you put those things together, the genetic susceptibility plus modern life, which is with unhealthy food, lack of physical activity, ultra-processed food, all these things, yes, they play a role. But I can't only blame the modern life. And I think recently there is a big, it's important article about the ultra-processed food. Now, they're saying still we don't have a robust evidence that to say if we stop all ultra-processed food from the market, then the obesity problem would be resolved. There's something in the body going, inside the body, of course driven by genes and triggered by the modern life that we live in.
Right. So that means we are constitutionally inclined to either gain weight easily or be able to maintain the weight easily, right? Now, is there a difference in the metabolism also because of this? Do you think this also impacts one's metabolic rate or decides how good or bad the fat metabolism would be based on this?
There is general rules, okay? every single person are subject to those general rules. And one of these rules, what we call it, metabolic adaptation. What's metabolic adaptation? I'll give you an example, for easy example, not on our body. If you have an employee who gets 200 dirhams a month, and he's happy, for daily expense, then all of a sudden there are problems happening, and he starts earning 100 dirhams. Can he expend 200 dirhams? He's going to reduce his daily expenses. This is what happened with our body. This is what we call it metabolic adaptation. Then slowing the metabolism, it might be the reaction of our body to save energy. Then if our brain, which is the machine to control the energy, senses that you are trying to lose weight or to lose some fat, which is energy storage, definitely your brain will send a message to every cell in our body to slow the energy expenditure.
Correct.
Then this is what we call it metabolic adaptation. Then slow metabolism, it's a normal defending mechanism to save energy. And as usual, you hear probably from most of the patients that, doctor, it must be my metabolism might be low. Now, rarely we find, like, for example, underactive thyroid problems that can be fixed, maybe improve the metabolism. Diseases of other hormones. As an endocrinologist, I know that and deal with them. But I always tell them, say, if you have hypothyroidism, which is underactive thyroid, and I will treat you perfectly, don't expect that you're going to lose 20 kilograms in 3 months. That improve your metabolism, improve your general health, but that's not a treatment for obesity as a disease. Okay? Then my message is, obesity by itself, regardless of other diseases, other risk factors probably related to obesity, obesity itself is a disease of energy dysregulation. If I don't fix this energy dysregulation, it's very difficult to treat obesity in a lifestyle measures, like we talk about that probably, how we used to treat obesity.
I don't think anyone has simplified this whole thing as you did. So thank you so much for that. Out of curiosity, what do you think is the role of insulin resistance in this whole thing? Where does this fit?
Yes, insulin resistance is important, part of the obesity problem. Why? Because insulin, one of the hormones related to the metabolism and energy saving. Well, what's insulin? Insulin is a hormone secreted by the pancreas to get the glucose inside the cells to be used efficiently as energy. If you don't have enough insulin, the glucose particles will float in the blood vessels, and when you check the blood sugar will be high. Okay? Then what insulin resistance? For some reason, there will be a problem of the utilization of the glucose. Then the pancreas starts to produce more and more insulin to overcome this problem on the cellular level. Then the pancreas will start to produce more and more insulin to push the glucose inside the cells to be used as a energy, for daily activities. Then when the pancreas gets tired after that, then it fails. Then that's diabetes. If your pancreas works only 30-40% as a capacity, that's diabetes. You reach that. Then the surplus of the glucose that's not used by our cells at the moment, where it goes? As a fat storage.
Absolutely.
Okay? Then if you have insulin resistance, of course, you will be susceptible to have obesity. But I always tell my patient, insulin resistance and obesity, like the story of egg and chicken, which went first. Okay? Am I going to fix insulin resistance? If my patient comes to me and tell me, okay, doctor, please fix my insulin resistance, I'll tell him 3 things. One of those things are out of your hand, which is genetic. Sometimes there is a genetic predisposition to be insulin resistant, you have diabetes. Your lifestyle, of course, eating habits, specifically what we call it sugar rush. If you have always sugar rush, you eat too much simple sugar, then your pancreas will be always triggered and the insulin level will be high, and that increases the insulin resistance. And weight loss. If you lose weight, definitely insulin resistance
Yeah.
will
improve.
get better. Then insulin, one of the important hormones that we
Very
focus
important.
on,
Yeah.
really. But if your question is, if I treat insulin resistance simply with a tablet, would that fix the problem? No. That may,
Yeah.
alleviate probably some of that. You see good numbers of insulin in the blood test, but if you want to treat it really, it's a lifestyle changes in terms of the eating habits, specifically reducing sugar spikes, plus losing weight by, of course, medical supervision.
I have a few questions in my mind right now.
Yeah, of course.
So number one is, again, simply out of curiosity. I have just inherently I've noticed one thing is that the body responds very well to circadian rhythm. Like if we maintain a certain circadian rhythm for everything, it's not just sleep, but also maybe meal times, for example, it should have a positive impact on the insulin health as well in general. What do you think about it?
See, I mean, we know that from the studies that, for example, intermittent fasting, you know that?
Yeah.
Intermittent fasting, that has a good impact on insulin secretion. Because if you have a routine that you follow, usually, that routine may facilitate a good metabolism. Okay, that will help in having good metabolism. Now, once again, there's no one size fits all. Because many patients, they come to me, they told me, doctor, I've done intermittent fasting for ages, that did not help me. Yeah, I believe you. And the other people, they had never done intermittent fasting. I may tell them, do intermittent fasting, okay? I'll tell them, have a low carbohydrate, low sugar intake, and that will help, definitely. I have many people, they come to me, they don't recognize that they have any problem with their sugar metabolism. Their blood test, it's fine. There's no diabetes at all with the blood test. And there's the family history of diabetes. They're a bit overweight. Now, okay, let's do continuous glucose monitoring. We'll put a little device here on the arm and we check the blood sugar every minute. You can't imagine the impact of some kind of food in the blood sugar. The blood sugar shoots up to the levels of diabetic people or people living with of diabetes. And that also play a role in developing chronic diseases in the future. Then going back to the circadian rhythm, if you follow a specific routine, now there is some advice, for example, to have a late dinner, don't have food late. Specifically, you are more active throughout the day, then that's why we can consume more. But if you have the last meal at 11 or 12, midnight, of course you're not going to consume that. Even your cortisol level is low, your thyroid level is low, your growth hormone level is low. All those hormones are not really active to consume that energy that you take through the food. Yes, probably circadian rhythm, that's one of the things that we should focus on. Yes,
focus on, okay. And then what is this relationship with between cortisol and fat metabolism?
Oh, see, we know that very well from stress and lack of sleep.
Yeah.
The lack of sleep, now I tell always that the most difficult patient that I treat for obesity, shift workers. It's very difficult because they don't have a stable, or let's say rhythmic cortisol secretion because of that change of their sleeping pattern. And if you have high cortisol, always stress, that high cortisol definitely lead to fat storage, increase the fat storage. And that, again, related to stress and related to lack of sleep. Unfortunately, doing cortisol test by blood test wouldn't give you the full story. And if I link cortisol from disease-related things, I would say only there is one common disease called Cushing disease, where you have an abnormal continuous secretion of the high cortisol level from the adrenal gland. That's very rare. That's a different story. I'm not talking about that. But I'm talking about that our daily stress, if it is not manageable, then it may lead to weight gain. And also that increased appetite that makes you eating more and more. Sometimes stress eating, what we call it, we can talk about that, or
Absolutely.
the emotional eating.
Yeah.
That's one of the things also driven by
Yeah.
cortisol.
Yeah. And I think that's a different topic for a full podcast
Yes,
episode.
correct.
Absolutely.
Most likely, yes.
I just wanted to ask you one quick question. Do you think there is a relationship between all of this imbalance in hormonal, interplay and increase in the visceral fat levels, right? Specifically, do you think the belly fat, as people say, that I'm trying everything that I can do, but I'm not getting rid of this belly fat? So do you think this is the reason what basically causes the belly fat in specifically?
Yeah. Say, we know that the most dangerous fat is the visceral fat. What does that mean, visceral fat? Just for people to understand that. Visceral fat means this kind of fat that goes inside or around our internal organs.
Yeah.
Liver, pancreas, spleen, gut, bone.
Yeah.
Now, if there's too much fat in the pancreas, that's one cause of diabetes. Indigestion, because the pancreas, there's some enzymes got secreted from the pancreas for that. Liver, that would lead to what we call it fatty liver, or they change the name now a little bit because that we call it metabolic liver disease.
Yeah.
And that may lead to liver cirrhosis as well, like fibrosis of the liver. It's a very dangerous condition.
Absolutely, yeah.
if you left without treatment.
No treatment, yeah.
And this visceral fat, what we really always focus on to treat, because the fat that you see in the tummy, or like it's external fat, that's like a buffering system. It's a buffering system. It's not something to harm you, but it's a buffering system to stop the extra fat from going to the visceral fat. But when the capacity of the fat cells here around the tummy
exceeds
full,
its limit,
then they will, what we call it, spill over. Then that spill over go to the blood vessels. Then if you go to the blood vessels, then if you check your triglyceride in the blood test,
will be high.
very, very high. And it goes to the liver, you do liver enzyme will be high. You do ultrasound for the liver, there will be a liver accumulation there. Pancreas, again, insulin resistance. Then, of course, the visceral fat is the health-wise that we focus on. For example, when we treat people with obesity to lose weight, I always do a blood test for them, because I can find metabolic problems they are not aware of. It's not only about shape. I tell them always, as an obesity consultant, as expertise in this field, I'm not a cosmetic doctor. I'm not a doctor to just make your shape nice or recontouring. That's a different story.
Yeah.
That obesity is about health.
Yeah.
Because we know that obesity is linked to more than 225 medical problems. Some of them, as I said, diabetes, high blood pressure, and pancreas problem, liver, fat on the liver.
Yeah. That brings me to another question right now. I'm not even looking at my paper right
That's
now.
okay.
It's just I want to ask you genuinely these questions. What are the blood markers, metabolic blood markers, that you would say are very important, critical for any patient of obesity? If they want to manage, then these would be your important markers that you would definitely consider during treatment.
Yeah, there's a routine things that we do, okay, which is what we call lipid panel, the cholesterol and triglyceride, and that will give me an idea about it.
Yeah.
And even in the guidelines like that, triglyceride is part of the metabolic syndrome criteria. Blood sugar, it's very important.
Yeah.
We can do that blood sugar, or what we call it HbA1c, the average of blood glucose in the last 3 months. Liver enzyme, we do that. That might give me an idea about that. Sometimes we do what we call insulin resistance test, though it's not practically, changing the management plan. Because I see many doctors, they do like what we call it insulin resistance. They test, they send the patient to drink glucose and do the insulin before. But they do insulin also, insulin before, insulin after. It's not a practical test. We do it in the research centers, but it wouldn't change the management plan. If you are overweight, your blood sugar start to go up, I can do only fasting insulin in the morning. That can give me an idea. That's what we call it HOMA-IR. It's a score to find out if you are if you have insulin resistance. Yeah, I mean those are the basic things. Then I check the thyroid function, of course, the TSH. Cortisol, I check it, but I tell them, see, if it's slightly elevated, don't worry about that. I know maybe last night you did not sleep well, or you're a bit stressed, that's why your cortisol level it's a bit high. Now, if you want to dig more and more, you can, in male, for example, you can do testosterone level, which is the male hormone. Sometimes low testosterone leads to increased fat mass and loss of the muscle mass. We know that sometimes in female after menopause, the estrogen level goes down. Also that increase the susceptibility of 100%. Having increased fat mass. But I know if I have a lady who is 55 years old, then I know that her estrogen is low, then I don't do the test. But those I mentioned in the beginning, it's simply they give you an idea about the metabolic function of the body.
Yeah. I think we touched base a lot without even going through these questions. And now I will just kind of make sure that I don't miss out asking you something that I planned previously. So my next question is, how does obesity affect an individual's overall health and well-being beyond the commonly known risks like diabetes and heart disease?
See, first of all, let me talk about something very important, which is why we consider obesity as a disease. Obesity is a disease because the philosophy of a disease based on few things. First, there is an abnormal biological processes that lead to some symptoms and disturbances of the health. And that's what happens in obesity. Then the main problem, I believe, it's in the brain. That's we always say obesity is a brain disease. I sometimes interview my patients for half an hour or 45 minutes. I don't mention stomach. I don't mention gut at all. I always focus on the brain, because we know if you have a gastric sleeve, and you are left to do whatever you like after that, you'll end up after 3 or 5 years with weight regain. Back, the same thing. There's not a problem about cutting your stomach. The problem is about managing that center in the brain, what you call homeostatic center, center of energy security. That center, the day that knows that you can carry this level, let's say 120 kilograms, wouldn't be happy to go below that. It's that we call it set point, like a thermostat. You know, when you have a thermostat, if you set it at 27 degrees, regardless of the temperature outside, it's 27. Now, this center, to some extent, is auto-regulated. Like body temperature. Do you have a control in body temperature? Your body temperature 37. The temperature is 0 or 50 outside, your temperature 37. Then the same thing is auto-regulated, and there is a set point, and always your brain would defend for that set point. Whatever you do to lose weight, then will go up. Then that's why what we call the yo-yo effect. You know, most of the people they lose weight, they regain, lose, regain. Then because that center to come to the symptoms of obesity, because of that center tells you accumulate more fat. You can carry more. Can carry more. How you are going to get more fat? You're going to eat more. Then most important symptoms of obesity, what we call it appetitive symptoms.
So my next question is, if you consider obesity as a disease, then disease must have symptoms, right? So what kind of signs or symptoms you think are the telltale?
That's an excellent question, because I always, the theory here oppose the theory of blaming people if they eat too much, they will be fat. Or they do less physical activity, they will be fat. Now, I'll give you an example. If somebody got a chest infection, then definitely you start coughing, correct? When you're going to treat that gentleman, you can simply give a cough syrup, but that wouldn't fix the chest infection. The root problem is
still there.
Infection, it's bug. You need to kill that bug, then cough will settle down. when you have a disease of energy dysregulation, means there is a center in our brain, it's called homeostatic center, which is responsible of energy security.
Huh.
The balance between the signals says accumulate more fat, you can carry more fat, and the other pathway, which is enough fat storage, has been disrupted. Okay? Then this is what we call energy dysregulation. There's something in the brain says accumulate more fat. Where you can get that fat from? As we agreed before, fat is an energy storage. Then supposed to be there is an energy source, and that's food. Correct?
Correct.
Then because your brain wants to accumulate more fat, then you start feeling hungry. Then one of the most important symptoms of obesity is what we call it appetitive symptoms, excessive hunger. Many people tell me, doctor, I can't
Control.
I can't control. I want to eat all the time. Even 2 hours ago, I've eaten, then I want to eat again. That's out of their hand. That's not a choice. Secondly, inability to achieve fullness. Eat and eat and eat and eat. There's no signal going to the brain to say stop. That's another one. Third one is what we call food noise. Planning about food. There's an obsession. Obsession, planning about food, thinking about food, snacking between meals. Again, that's not a choice. That's a symptom of energy dysregulation, because your brain wants you to accumulate more fat, then you will eat excessively. Okay? Now, the other part of the symptoms that we have, it regardless of diseases related to obesity, probably physical dysfunction.
Where?
If you are 120 kilograms or more, whatever, then that would lead to some disability, difficulty to perform your daily activities.
Yeah.
Sometimes shortness of breath, without any heart or lung disease. Okay? And the third part, which is really important part, which is the mental part. What we call it dysphoria. Dysphoria means simply feeling unhappy. But that feeling unhappy may lead to depression, anxiety, social isolation, correct? Lack of self-confidence, lack of self-esteem, and many cases of suicidal attempts. We know. Then mental symptoms, appetitive symptoms, physical symptoms, all these are symptoms of obesity as a disease, regardless. I don't talk about diabetes or blood pressure. And you know, probably that's an advantage, you know, because you don't know a person got hypertension unless you check his blood pressure.
Yeah.
You don't know a person has got diabetes unless you check his blood sugar.
Yeah.
But that's a very obvious symptoms
Yeah.
to say this is a disease of energy dysregulation.
Yeah.
This is obesity. Please fix me.
Yeah.
But unfortunately, we used to think the opposite way.
Yeah.
We used to think that because we are eating excessively, and still, unfortunately, still we have doctors till
Yeah.
this date blaming people because they are obese.
Absolutely.
Tell them, please eat less and move more. Eat less and move more.
Yeah.
An example about the, you know, American health system is a good health system, and there is planning.
Yeah.
Then in 1990, they have like a programs called Healthy People. They plan for 10 years. At that time, the obesity prevalence was 13%. And they said, in 10 years, our plan, sorry, it was 17%. And they said, in 10 years, we are going to go to 13%. That wasn't like, they did not say 0%. They want to reduce 4%. And then change the policies. They've done, you know, work about campaigns about eating healthy, improve physical activity in the school, less sugar, less processed food. Guess what? In year 2000, the obesity prevalence, 23%. Now, you know, another 10 years more, now it's 40%.
Yeah.
If obesity as a disease can be fixed by eating less and moving more, and they know from their statistics, they've done a great job in terms of educating people to eat less unhealthy food, to eat more healthy food, to be more physically active. They know that from the data. They know that statistically. But the prevalence of obesity is going up.
It's still going up.
Then it's a disease. There is symptoms. And when we treat now, we can talk about how we treat that disease. When we treat that disease, those appetitive symptoms disappear within 2-3 weeks. Disappear. The people tell me, okay, that's magic, doctor. Oh, what was this medication that you gave me? And all good now. I'm not feeling hungry again. I'm not feeling.
Interesting.
There's no food noise, nothing clear.
I have 2 questions right now. The number one is the mechanism that you're talking about. Is it the HPA axis mechanism? Is it something close to?
It's in hypothalamus.
Hypothalamic pituitary axis?
Yes,
mechanism?
it's not pituitary specifically, but it's hypothalamus, and mainly the axis between the gut and hypothalamus.
And the brain, yeah.
Correct. And
Very
mainly between
interesting.
gut and the brain.
And the brain.
Because the basic things now that, the discovery really, to know how to manipulate that homeostatic center in our brain, in the hypothalamus, it comes really from gut hormones.
Yeah.
And those gut hormones were manipulated earlier by bypass surgery, the bariatric surgery. But they thought it's only like a malabsorption, just to reduce the absorption of the food, or to cut the stomach and reduce the size of the stomach. But unintentionally, they've done something which is related, what we call it metabolic surgery now. We changed that. Then probably all this invention or discovery of the new medication for anti-obesity, it was really, a lesson from the bariatric surgery.
Yeah.
But yes, that's what we call gut-brain axis.
Brain axis. And then does that, so I'm trying to also connect, because it's what you're saying is gold, right? And I want everyone who's listening to this to also understand the science behind that.
Of course.
So do you think it is the leptin and grillin that it essentially affects?
Yeah. Leptin and grillin are very important hormones, but unfortunately, we couldn't use them to treat obesity. There are many reasons. One of them, what we call it leptin resistance.
Yeah.
Similar to insulin resistance.
Yeah.
And leptin, for people to know, leptin is a hormone comes from the fat to promote satiety.
Correct.
To feel full.
Correct.
And there is another hormone called grelin. It comes from the stomach.
Yeah.
To make you feeling hungry.
Yeah.
Okay? Now, when they cut the stomach and the gastric sleeve, they remove the big part of the ghrelin-producing cells. But did not solve the whole problem. It's still there. When they cut the stomach, then after that they come and regain weight, because there are other hormones.
Yeah.
And the hormones, they're very, very effective now, what we call it glucagon-like peptide, GLB hormone, GIB hormone.
Yeah.
Those hormones not in the stomach. Those hormones in the gut, in the small intestine. Then leptin and ghrelin are very important hormones. Now, for satiety and hunger, there are more than 13 hormones. Comes from the fat tissue, from the pancreas, from the gut, from the stomach. But using them as a treatment wasn't successful. Leptin and ghrelin. Like, if you have a medication to reduce ghrelin or to activate leptin, theoretically, it should fix obesity, correct? This is what we are arguing now.
Yeah.
But unfortunately, in the researches did not conclude that it might be
positive in
practically, successful in the real life. But they were successful with the GLB and the GIB.
Yeah. So while we're talking about the treatment side of things, can you tell us now what approach would be, in your opinion, with your experience in treating obesity for so many years now, what should be? So I know that there is no one-size-fits-all approach, for sure.
Of course.
But then, according to you, what should be the right way?
Yeah. So we try to phenotype obesity. We say this is obesity because of that reason. You are obese because of that. You are obese, like, for example, if you have a heart disease. I'll tell you this heart disease because of this, or because of that, because of you have coronary artery problems, or because you have valve issues, correct? Unfortunately, till date, we don't have that clear view to fix that. And that's what we call it obesity phenotyping, or try to individualize the treatment, okay? Still, we treat obesity in a holistic way. But I believe in the future, we are going to have something. There's the good trial in the Mayo Clinic in America. They phenotype people to 4 different phenotypes. One it's called hungry brain. Those people can't stop eating. And another one, hungry gut, where they eat and after 2 hours feel hungry again. Feel hungry again. And emotional eater, which is the big topic that you said, and low metabolism or slow metabolism. Then that's one of the phenotypes. But they started to develop like a genetic test or something to say this is your
responsible
problem.
for this.
But again, how I treat it.
Very true. Absolutely.
You know, is there any different treatment for hungry brain or hungry gut? I don't know. Still, okay. Then it's a good step in the, you know, probably development of obesity science. But practically, there's no changes. Now, obesity management should be very holistic, you know, approach, comprehensive approach. The reason behind that, the consequences of obesity, more than 200 diseases, symptoms of obesity, mental, physical symptoms related to appetite. I have many people living with obesity. They cried in front of me many times because they had been bullied. They've been, you know, stigmatized. They said, okay, you're responsible. All the blame is there, you know. Then you can't simply write a prescription and give it to the patient and tell them bye-bye, I'll see you in 3 months. You know, it's like a GB, for example. You should be interested in treating obesity, okay? You should have the passion to deal with people with obesity, and that you'll be really successful.
Correct.
Now, holistic obesity management, I believe, would involve many aspects. One of them, to give your patient a good time, to listen to your patient, to listen to the long story. And I tell them always, obesity is a chronic disease. Tell me whatever you like in terms of your journey. Sometimes there is a big life event, and this big life event was the trigger of a big jump on the body weight. Divorce, relocation, marital strife, problem at work, always like big. Then it's good to listen to those things, because that would relieve the stress on that person, and you feel okay. There's some reasons out of my hands, not in my hand. But then probably giving the patient, the person lives with obesity time to talk and listen genuinely, not only listen and we are, you know, writing your notes or looking at your computer. That's very important point. Now, we incorporate, I believe, lifestyle coaching, what we call it. I have a variety of patients. Some of them, they don't have any nutrition literacy. They don't know the difference between protein and carb and fat. That's important. They should know that. Correct? But I'm against any very strict diet. The reason behind that, you can't use lifestyle as a therapy. Because if I tell you stop eating bread, potato, pasta, rice to lose 10 kilograms, how long can you do that?
Very true.
1 month, 2 months? Then this is the lifestyle. But I should teach you. If you go to open buffet, all the options in front of you, which one you choose? That's your choice. And you may have once a week what we call it cheat day. You know, many people, they ask for that. What's a cheat day? You can do it, it's fine. But you are the decision maker in terms of what you're doing. Then these things are nutrition literacy. Physical activity is very important, because when you lose weight, you may lose muscle also, not only fat. We need to improve the muscle bulk, improve the muscle endurance, and that also needs education. Needs education. That's stress management, very important. Sleep hygiene is very important. Then that's part, of course, by a nutritionist, by lifestyle coach, may happen. But once again, all these things, Priyanka, you know, in the part of the brain, what we call it frontal lobe in the brain, those are executive function. You decide to eat this, not that. You decide to go to the gym to do physical activity. But remember what I told you before? The main problem, where's the machine to control the energy, is in the hypothalamus, in the deep brain, which is out of your control. Then if you do this, you may lose 10, 15 kilograms, but you go back to the previous habits
Again.
and you can regain weight. Then if I don't fix the energy dysregulation, I wouldn't get the good results. The lifestyle changes, very important, but to adopt a healthy lifestyle.
Yeah.
And in my opinion, there's 3 conditions for the healthy lifestyle. Doable on daily basis, enjoyable, and sustainable. If this is not, 3 conditions there, it wouldn't be a healthy lifestyle. You can't do.
Perfect.
Correct?
Perfect.
And the treatment, which is really was revolutionary, changes the obesity management. This is what we call it hormonal or biological therapy.
Yeah.
Then many people, they know about the injection. They inject every week, once a week, for example, that we call it incretin-based hormones. Those are very, I'm not going to say names because that's not for marketing, but those medications really changed
Yeah.
the whole picture.
Yeah.
Very effective, but they should be used under medical supervision.
Absolutely.
Shouldn't be used for a short time and stopped without any plans.
Yeah.
Shouldn't be used lonely without lifestyle
Yeah.
and nutritional therapy. That's very important. And the psychological part, it's really important, or mental part, because once again, if there is emotional eating part, then that should be addressed very well, because that will help in the management of obesity. And I have many patients, they have like extreme depression. I refer them to psychiatrists.
Yeah.
Because if I don't fix that, I can't fix obesity.
Yeah.
Then
Yeah.
it's a holistic approach for all
Yeah.
these things.
Yeah. Yeah. Okay, so I think just one last question. We all know these upcoming medications that have taken a world with a, full swirl that is really working really well. And so in your opinion, what's your experience and what do you recommend?
I would say those were like revolutionary medications, of course. They've changed the way that we deal with obesity. As a, specialist in that field, we used to advise people to eat less and move more, unfortunately, before. Yeah. that was the way how we deal with obesity. And if I'm a brilliant doctor and my patient is very disciplined, really, I can help them losing 5% of the body weight and maintain it for 1 year, 2 years. Now, with this new medication, we can reach 20 to 25% weight loss. We should admit that's a great invention in the field of obesity management. And those medications, the two medications that we use them, probably the people, they know them very well, but I always say that a hormone.
Yeah.
Okay, that's a hormone changes things in your body.
Yeah.
Then should be used under medical supervision.
Yeah.
It shouldn't be a friend prescription. It should be a doctor prescription. I know that probably here, I'm not sure in other country, they can buy it from the pharmacy without any prescription. They can inject. But I have bad stories with people took this medication without medical supervision.
Yeah.
Either they waste their money and time because they did not do it in the proper way.
Yeah.
Or they have complications, which is, unwanted, and unpleasant one.
Yeah.
But medical supervision is very important to take the patient through a good journey. See, always there are many stories embedded in the obesity journey, and those stories very important in the obesity management. It can't be fixed by medication only. Just give medication and go. We can't do that, and that's why probably the trust between the patient and the doctor. How I'll tell him, okay, this medication is good, then he will believe me what I'm saying, because I'm expertise in that field, and that medication should be taken at least 6 months, 1 year, maybe you take it for life. If you have a severe obesity and your excessive hunger is out of your hand, and if I try to stop the medication at one stage, most likely it is a lifelong medication. okay, then we need to agree for that.
Yeah.
With full respect, the pharmacist can't tell you that.
No.
And your friend can't tell you that, okay?
Yeah.
And those medications, like probably you know the names Monjaro, or what called terzabetide, or Wegovy, what we call it semaglutide, those are very effective medication. Now, we have many other medications earlier, not very, probably 5 to 10% weight loss, but now we were getting 16 up to 22, 23%.
Brilliant.
And also for your information, or for the also audience information, in the pipeline, there are more than 30 pharmaceutical companies
How amazing.
working on the same field, and the same, I would say, mechanism of action. How those hormones can fix
Yeah.
that energy dysregulation in the brain, and hopefully in the future, because we have a big problem now.
Yeah.
Cost,
Yeah.
insurance cover,
Yeah.
it's a big problem.
Yeah.
And when we talk about obesity prevalence, it's 30, 40%.
Yeah. Yeah.
I mean, we need a cheap drug, really. We need a cheap medication. But hopefully, when we have many competitors,
Yeah.
in the pharmaceutical field,
Yeah.
with effective medication, hopefully the price will
Yeah.
go down. And I'm pretty sure that in the coming 5 or 10 years, it
It
will be
will.
accessible for people need that medication. Now, let me conclude with one thing. We need to differentiate between obesity as a disease and people who have that, what I call it, cultural desire of thinness.
Dysmorphophobia. I call it the dysmorphophobia, right?
Then this is another disease. This is not a disease.
It's a different,
Okay?
yeah.
Then
Yeah.
that's, if you want to lose 2, 3, 5 kilograms for a social reason, for a
Yeah.
cosmetic reason, that's not a disease, okay?
Yeah.
But also I meet many people, they came to me with that concern, but they really have the disease, what we call it, energy dysregulation, obesity.
Yeah.
When I do the blood test for them, then I took that, opportunity to further investigate, find out what metabolic problems that patient have, what other negative impact on their health. I tell them, yes, you want to lose weight to look better,
Yeah.
but I will help you in gaining health.
Yeah, yeah, that is so good what you just said, gaining health, right? Because it's a full spectrum kind of a concern. It's not just about weight, right?
Correct.
And I don't know, how can I tell you, I absolutely loved this conversation.
Thank you.
Number one, because you have an approach which scientifically goes to the core problem, right? And then to overcome that problem, you have a very multifaceted approach, like a full circle approach, right? It's not only about that problem to be resolved, but it's also what other things that are engaging that individual to not achieve, the
Correct.
the correct the health in the long run. So I absolutely love that, and I also cannot stress on the fact what you just said is in the beginning, and the whole, I would say, heart and soul of today's conversation was around that, is even though I might want to eat well, might want to move more, I'm still not able to, right? How
Correct.
is that my fault? And so fixing that, it's such a deep-rooted
Yes.
issue,
Yes.
right?
Yes. Then this is again what we call it. It's not a personal choice.
No,
It's not a personal
not
choice.
a
Now,
personal
see, I'm not
choice.
saying that. I'm not underestimating the willpower.
Yeah.
I'm not underestimating the conscious act that you can take
Yeah.
at some stage.
Yeah,
But if you can't do it, stop and seek medical advice.
yeah,
Simply.
Yeah.
Okay? If you can do it, it's fine. That's okay. But if you can't do it, it might be out of your hand.
Yeah.
Don't go to that vicious circle
Yeah.
of feeling guilty.
Yeah.
Feeling that I lack willpower.
Yeah.
I lack self-discipline.
Yeah.
That's the problem. And
Yeah.
then it's a vicious circle.
Yeah.
And that's frustration.
absolutely.
No, seek medical advice.
Absolutely. So I think in now concluding this conversation, and as we wrap this episode with Dr. Hecham Harb, thank you so much. Thank you for coming, and thank you for sharing all this
Pleasure.
information. This really was such an amazing conversation. I would, just to end this episode on this note, I would like to end it. After delivering my second child, I definitely gained a lot more weight than I should have. And that was the point where I was, I think, lowest in terms of my metabolic health. That was the first time in my life that I had high cholesterol also. I didn't want to move. I would never be full. I would eat a lot more than I should have. So that point of fullness, like what you said, was gone, completely erased. And then what used to happen is that I would end up feeling like so down, right? No energy, fatigued because of
Correct.
that spike
Yes,
now.
yes.
And that was a vicious cycle. I wouldn't want to move more. I was exhausted and it wasn't working out for me. So I think those of you who really want to overcome this status in life, you really need to, take steps back and revisit, complete story, like what you very rightly said, that you always ask the full narration from your patient to go back in time and tell you exactly how it started, what all that they are feeling and everything, all the information, to then really go through your personal health details, your blood markers, your eating habits, sleep habit, hydration level, physical. And only when you take this complete history and then treat this condition, you would get the most sustainable solution, right? Obesity is a prevalent epidemic and it's a multifactorial condition. And I think it's like an etiology by itself for multiple different health conditions, whether it is heart condition, PCOD, you name it. And those conditions can be largely improved if you work on your weight management. So on this note, I would say take care of yourself, your mental health, physical health, your well-being, and until next time, bye, Kush Raho.